Bismillahirrahmanirrahim. Welcome you all to our regular weekly webinar. So now we are discussing real life case discussion, and now we are running the breast cancer series. Today we'll be talking on adjuvant therapy, but we will not touch upon radiation and endocrine. We will only touch upon the chemotherapy and the targeted therapy. So today we have three overseas faculties, Dr. John Conivier, Dr. Kumardeep Datta Chaudhary, and Dr. S.K. Farid. Dr. John and Farid is representing UK, and Kumardeep Datta Chaudhary, he is from Advanced Cancer Center, Delhi, but he is a man from Assam and Bengali spoken person. And our local faculties is Dr. Asma Siddiqa, who is the Associate Professor of Radiation Oncology in NICRH, and Dr. Ruxana Rabbani Dina, Assistant Professor of Radiation Oncology at Dhaka Medical College Hospital. So as per custom, we want to start with our President and Patron, Professor M.A. Hai, sir, with few words from you, sir.
Thank you, Kamal. Bismillahirrahmanirrahim. Heartfelt welcome to all of you who have joined here, particularly the overseas consultants, but member of the panels, and also our local experts. Today our subject is adjuvant therapy of breast cancer. So without any delay, I think we should start. Kamal, over to you.
So thank you, sir. Sorry? Please mute others. So the session will be on 60 minutes, and we'll be talking on the case-based discussion. So we start with the case. Is a 45 years old premenopausal lady who presented with a lump in her right breast. Ultrasonogram base showed a 4 centimeter tumor in upper outer quadrant of right breast with right X-ray lymphadenopathy. 4 biopsy showed invasive ductal carcinoma. Metastatic workup was done, but no hormone receptor status was done. And the patient underwent a mastectomy with axillary resection. And then the pathology came out to be invasive ductal cell carcinoma. Thereafter, the pathological tumor was T2 to 3 centimeter in 0/11, grade 2. And now when the hormone receptor status was seen, it was ER/PR positive, HER2 negative, and Ki-67 13%. And then predict score was done. Predict score shows that surgery only for 10 years can give 93% benefit, and chemotherapy can offer less than 1% benefit for this patient. So Shorna, now please give the first question. Show the first question. So what will be the most appropriate adjuvant therapy for a 45 years old premenopausal PT2 3 centimeter N0M0 grade 2 ER/PR positive HER2 negative Ki-67 breast cancer patient? So there are quite a good number of selection. You can select any one. Just want to know, see how we are thinking. So only 6 out of 27 participants till now voted. We want more participants to vote, and every year time we are giving 3 prizes. We will be declaring the prize for the last session very shortly. So only 28% 9. Please, we appreciate more. It's more than 1 minute. I think. So Shorna, I think we can stop it here. So nobody voted in favor of 4th cycle of AC. 1 favored 4th cycle AC followed by endocrine therapy. 3 4th cycle AC with 4th cycle taxane with endocrine therapy. 1 dose dense 4th cycle AC 4th cycle taxane with endocrine therapy. 4 out of 11 chemotherapy decision based on oncotype DX score and endocrine therapy, and 2 endocrine therapy. I like it. I mean, this was actually what we wanted, that the group should be divided, because this is an area where world is divided. So this was the question. Now coming back to our local faculties. First, I want to ask Dr. Dina, in this situation, what will be your take? How you will give her adjuvant treatment? Dina, please unmute yourself.
Yes, sir. Thank you, sir. I want to give adjuvant treatment with chemotherapy first because she is still a premenopausal woman with a 3 centimeter tumor, and I prefer to give AC followed by T. Then go for endocrine treatment.
Sorry, you want to give 4-cycle AC followed by 4-cycle taxane, then you want to give endocrine therapy. Dr. Asma, will you be with Dina or you want to make something different? Please unmute. Asma, please unmute. Dr. Asma. Please unmute yourself, Dr. Asma.
Thank you. I totally agree to Dr. Dina. At first, I will go for chemotherapy, then endocrine therapy.
Great. So I have 2 foreign faculty here. Before going to them, let's make a quick. So let me change the scenario, Dr. Asma. If the same patient comes to you with N1, there is 1 node positive. Will you do any change or will you do the same treatment?
Actually, in our scenario, we have no change to the protocol. We exactly treat as this case. That is, we will give offer her adjuvant chemotherapy followed by hormone therapy.
So my question is, will you give 8 cycle in N0 and 8 cycle in N1?
Usually we don't change in chemotherapy cycle. Usually we go for 8 cycle, 4 cycle AC and then 4 cycle T. But duration may change.
Okay, very good. So we know that the factors that we need to consider for adjuvant is the size, lymph node status, and grade. In addition, we also need to look the ERPR and HER2 receptor status, LBSI, Ki67, tumor margin, and to consider the tumor burden, we need to look at all about these things. And very important is we need to look at the patient's preference also. Now, if we look at the NCCN guideline, it is quite a busy slide. In post and premenopausal women, they are telling that to prefer to oncotype DX. And then according to the risk stratification, they are telling to give chemotherapy, anything more than 0.5 centimeter. In ESMO guideline, if you look, they are telling that in luminal A, you don't need to give chemotherapy, only hormone therapy. In select cases, you can go for chemotherapy in high disease burden. Luminal B, they said, well, you can give. In Pan-Asian adapted guidelines, it is almost the similar message they are trying to give. So in this abstract of an old paper of adjuvant therapy of breast cancer from USA Consensus Conference, they have shown that unless over 80 or 70 years node negative, I mean, most of the patient get some benefit from adjuvant therapy. This trial, everybody talk, EBC TCG trial, and they have shown that this meta-analysis have shown that 100,000 women, and they have shown that there is a benefit of adjuvant treatment. And 2021 is now telling to do oncotype DX, even for node positive postmenopausal. And in this phase 3 plan B trial of West German study group, they have shown that there is a relationship of Ki67 less than 10% to more than 40% with the benefit subgroup classification of beneficial group of adjuvant therapy. And in node positive, again, now they are telling that we should go for risk stratification, and they are recommending category 1 is the chemotherapy. And ESMO is telling 1 to 3, maybe. And the long-awaited RxPonder study, now they are telling that adjuvant therapy may be de-escalated to endocrine therapy alone in postmenopausal patient with R score less than 25 in 1 to 3 node positive. So with this situation, now I come to Dr. Kuldeep. Welcome to the session, Dr. Kuldeep.
Yeah.
Sorry,
Good.
Kumardeep. Sorry, I'm sorry for that. Kumardeep, sorry. So Kumardeep, sorry for the mistake. So in our perspective, you are from Assam. So
Mhm,
Oncotype DX is expensive. Patient cannot afford it. It is not readily available.
mhm.
Would you like to suggest Oncotype DX or go for overtreatment?
Like I'd like to say hello to all, because my ancestors are from Bangladesh only. Actually, during partition, my grandfather was born in, and my father was also born in Sylhet district. So after partition, they had shifted to Assam. Now I am practicing in Delhi. I was in Rajiv Gandhi Cancer Institute for 12 years, from 2007 to 2019. And then onwards, I had left Rajiv Gandhi. So basically, all throughout in Rajiv Gandhi, most of the time I had practiced breast cancer, because I was in the breast unit. So basically, the problem with I think Bangladesh, India are almost same. The cost of Oncotype DX is prohibitively high. So in India, we also do EndoPredict, another prognostic marker. But again, most of the time, though it is comparatively less in costing, but because of the cost, half of the patient opt out of that. So most of the time they go for they give chemotherapy, because chemotherapy cost is, in any case, chemotherapy cost is less than whatever the cost of Oncotype DX or EndoPredict will. So ultimately, cost factor comes into the mind of the patient. But yes, this is a typical case. In our practice, what we do, T2 N0 disease, ERPR highly positive, strongly positive, 70-80% or beyond. Definitely, we advise for, you can avoid chemotherapy, go Oncotype DX. If it is low score, we can avoid chemotherapy and go for radiation if required, or directly go for endocrine therapy and no need for the chemotherapy. And if it is high score, you have to go through all this. Again, one of the risk factor for her is that she's young. She is young, and if she is not very much willing for Oncotype DX, probably I will give chemotherapy. Now, next question is what chemotherapy? Yes, the standard is AC followed by 4AC followed by 4T. I will not give dose dense because she is ERPR positive. So dose dense usually I give in triple negative younger patients where the risk of recurrence is high, or something like
So
that.
Kumar, my question is, with no node, will you give Taxane also, or you will be adding only 4-cycle AC? If it is negative.
Sometime, if we are planning to give 4-cycle only, we usually give
ഇല്ലാതെ അമോറിയയിൽ തന്നെ കറങ്ങിക്കൊണ്ടിരുന്നു. പിന്നീട് ഒരു വഴിയുമില്ലാതായപ്പോൾ
if we have to give 4 cycle of chemotherapy only, usually we give TC, 4 cycles of TC, and that's it.
Okay. So Kumar, we have somebody very interesting. Farid is from Bangladesh, but now he is a British because he is there for 20 year plus. He is a surgeon, but he's a very active person in MDT. So unless John join, he can take over. So they believe in predict score, and they are a damn believer of predict score. So Farid, few words here. Predict score is less than 1% benefit. Will you go for chemo? No Oncotype DX.
Thanks very much. As you said, if predict score is less than 1%, then we can safely avoid doing an Oncotype DX. Question of Oncotype DX comes when there is like 50-50, like debating when the score is 2.4, something like, survival benefit, or something like 2.5 to 3. That's when we agree for Oncotype DX. And if the Oncotype DX score is more than 25, then obviously we would consider adjuvant chemotherapy with tamoxifen for 10 years. Now, Ki67 is a validated indicator. Not every breast unit in UK are practicing Ki67 because it's not standardized. The reason being, different center, it measures it in a different way, and there is nothing like a standardized. That's why many centers prefer not to use that. But again, it depends. In my unit, we don't use Ki67 anymore for its good number of years. But predict, we are seriously using it. If the score is that low, we don't even bother for Oncotype DX. Thank you.
Kumar, I had a discussion once with Joya from TMH. They were telling that, well, we can use predict. But the question is, well, these are all nomograms. We know many nomograms are there on many sites which have some 95% validity. I mean, validation, not 100%. I mean, UK they are using. So are you using in your practice in Delhi predict scoring? Dr.
Yeah,
Kumar.
yeah, we are using quite a lot. Predict scoring we are using. Even those who are not going for any of the scores, we usually try to figure out what is the Ki-67, what is the grade of the tumor, what is the age of the patient, what is the family history. So if these 3 factors or 4 factors are coming positive, yes, then definitely we give chemotherapy.
So let me change the scenario. Patient is not eager to give chemotherapy. And she is asking how much I am taking a risk in this scenario, not doing Oncotype DX. I don't want to give chemotherapy. Kumar, what will be your answer to the patient? You know, like patients are very difficult to handle.
Like my typical answer is that whatever the risk factor is, 3%, 4%, it is 100% for you. Either there will be no recurrence or there will be recurrence. So whatever is happening to you, it will be 100% for you. So if I say the population-based data, it may not be applicable to you because as a single patient, it is not that useful. But as the breast cancer numbers are high and 3% or 4% make a good difference. So like say in India, 50,000 cases are being diagnosed as breast cancer. So 4% in 50,000 is a good number. So we don't know in which group you will fall, but most of the time they are not going for the test. Hardly any patient I find who are not willing for chemotherapy and not for testing. Usually those who are not going for the testing, they usually, yes, will take some form of chemotherapy, maybe 4 cycle, maybe 8 cycle.
Yes, I get your point, Kumar, that what you said that unless we do till now, predict is a good scoring system. We can take help of many other informations. But if somebody really want to challenge someone scientifically, till now, the only validated tool is Oncotype DX, which is unfortunately very expensive, not very available. So I totally agree that with all my colleagues that we can offer her 4 cycle TC, 4 cycle AC. If somebody is overkill, can give her 8 cycle, I don't mind. But we can explain her that the benefit is expected to be this low. And as you said, that is a very tricky thing in statistics, that even 1%, if she fall in 1%, she will be a victim of 100%. But again, the probability, chance is only 1%. 1 out of 100 is the chance. So nobody really knows the real answer. And even in Oncotype DX, the funny thing is they are not giving you 100%. They're giving you 95% of the benefit of doubt. 5% risk still we are carrying with Oncotype DX. So nothing is 100%. But well, this is a ever-going debate going on. And I think when the scenario change, when there is one node positive, when the lady is young, when the grade is 3, or when there is a strong family history, as you said, all these things comes in the play, and we need to be very cautious in the discussion. But when we are talking, we need to consider everything. Breast cancer is a very peculiar disease. Only TNM doesn't work. That's why the new HSCC staging has incorporated ERPR and HER2 there, and hopefully something more will come and it will tell that how we will deal. So unfortunately, till now, we cannot give a 2+2 answer to this question. The answer is we can give, maybe 8 cycle will be too much. If somebody want to give 4 cycle, maybe fine. Maybe I will go for AC if patient is interested, or if patient is courageous, can wait with endocrine therapy. And again, if somebody is rich enough, we can go for Oncotype DX. So we can go to the next case scenario. Now the lady is 40 years, premenopausal. Now their tumor is only 1.5 centimeter, invasive ductal carcinoma, underweight. Again, for it, don't ask me why ERPR was not done. It was not done, but breast conservation was done, SNB was done, and the tumor is invasive ductal carcinoma. PT1 1.5 centimeter in 0. Sorry, it should be SNB 0, not 11. Grade 2 ERPR positive, HER2 positive, Ki-67 20%. Now, Dr. Dina, what will be your treatment?
So after discussion with the patient definitely receive anti-HER2 treatment. She's HER2 positive, and chemotherapy is. I want to offer chemotherapy also, and then after completion of chemotherapy, anti-HER2 and hormone will be continued.
Great. So let's see how our participants say. Shorna, let us see the opinion poll on this question. How our participants divide themselves. Anti-HER2 chemotherapy, 4 cycle, 6 cycle, 8 cycle. So Shorna, next question, poll question. Shorna, yes. So first option is 4 cycle AC with trastuzumab for 12 months with endocrine therapy. 4 cycle AC, 4 cycle taxane, trastuzumab for 12 months. 4 cycle AC, trastuzumab, pertuzumab, 12 months with endocrine therapy. Only trastuzumab and pertuzumab for 12 months. Only trastuzumab, 12 months with endocrine therapy. So there are quite a bunch of things. I would have given 6 month trastuzumab one option. That could be another interesting option. So till now only 3-4% joined. 35, 6, 7, quick, 8. Only 31% responded. Please, we want more people to join. Still 42%, not 50%. Maybe we cannot create enough. So we stop it. Shorna, stop. So option 1, 4 cycle AC with trastuzumab, nobody was in favor. 10 out of 17 was 4 cycle AC, 4 cycle taxane with 12 months of trastuzumab and endocrine therapy. 3 out of 70 is 4 cycle AC, trastuzumab, pertuzumab 12 months. And 2 out of 17 is trastuzumab and pertuzumab, only no chemotherapy. And on 2 is trastuzumab for 12 months with endocrine therapy. So again, I'm so happy to see that our participants are splitting with them all. So this is a good to see. So now the question is to Dr. Asma, what will be your talk?
Thank you. I am in favor of oncotype DX. If patient is not afford to do this, I will go for chemotherapy as the tumor size is 1.5 centimeters. Then I am in favor of.
Positive, Appa, you made a mistake. It is not ERPR positive, HER2 positive, HER2 negative, right? HER2 positive. Will you go for oncotype DX in HER2 positive? It is HER2 positive.
Okay. Then yes. Then I will offer him anti-HER2 therapy for 1 year.
And
endocrine therapy.
Anything else? You want to give anti-HER2 only trastuzumab or pertuzumab?
Yes. As this patient is 40 years and tumor size 1.5, KI is 20, ERPR positive, HER2 negative positive, I will give him offer him single drug. That is
trastuzumab.
Trastuzumab, only trastuzumab.
No pertuzumab.
No,
Okay,
no
chemotherapy. No chemotherapy. Will you give her chemotherapy or not? That is the question.
Yes, I will give him chemotherapy.
What chemotherapy will you give?
Usually we will go
AC,
for
TC or AC taxane?
only AC followed by T, taxane.
Okay, 8 cycle. Great.
Yeah.
So we have our 2 local faculty. They are in favor of giving her chemotherapy. Nobody is in favor of giving pertuzumab. Both of them are in favor of giving trastuzumab. Kumardeep, by sequence.
The stage is stage 2A disease, node negative disease, and less than 2 centimeter. Tumor size is less than 2 centimeter. So if we see NCCN guideline, what they say, anti-HER2 therapy category 2B recommendation, and stage wise.
Please mute everybody. Kumar, you can unmute yourself. You are a co-host. Yes, please.
My take on this case will be, I will not give chemotherapy, and there is no data, I mean good data for adjuvant pertuzumab in node negative disease. High nodal burden, adjuvant setup, pertuzumab, yes, definitely it is yes for pertuzumab. But unless we are giving neoadjuvant therapy or post-surgery, it is high nodal burden, then I will consider for pertuzumab. So for me, it will be no chemotherapy, only trastuzumab for 1 year, maybe 6 months if the patient's affordability is a concern, and then along with that, adjuvant hormone therapy.
Farid, I know you are a dual blockade neoadjuvant believer. Unfortunately, this patient didn't get that. We will come to that discussion. So patient is now here on your MDT. What normally your MDT will do?
Thank you. Well, this lady is a slightly challenging one. We would discuss this in UK. HER2 blockers are licensed with chemotherapy only in National Health Service, meaning she has got about 2.4% benefit, 5-year survival if she gets chemotherapy. But because she's HER2 positive, we would offer her chemotherapy plus HER2 blockade, single HER2 blockade. She hasn't got a huge tumor burden. If it was a huge tumor burden or high aggressive tumor pathology, we would have considered dual HER2 blockade. But looking at the results that you have given, I think single HER2, just trastuzumab, chemotherapy and trastuzumab followed by hormone therapy would be recommendation in our MDT.
So you are not in favor of chemotherapy, only trastuzumab hormone therapy?
No, it is licensed. Trastuzumab is licensed only with chemotherapy at National Service. So we will have to give her chemotherapy.
So you are sitting in UK, now you're with NCCN. NCCN said that more than 1 centimeter go with chemotherapy and trastuzumab. So good to see that there is a good marriage between NCCN and NICE. If you look at the paper that this APT trial, this APT have shown that initially for 3 years, they have shown only 2% benefit of adjuvant trastuzumab with chemotherapy. But long-term data have shown that addition of chemotherapy with trastuzumab is giving a good survival benefit. That's why this early stage recommendation more than 1 centimeter probably came. And there are some more data, but the problem here you see less than 1 is 100%, but when it is more than 1 centimeter, then the things are changing. But the problem is all these are single arm study, and there is difficulties in doing RCT for large sample size. But this is an interesting paper in 2022 ESCO annual meeting. This Chinese group, they have shown from the CR data that if there is no chemotherapy, non-chemotherapy, non-breast cancer specific death and breast cancer specific death, you can see there is no difference. And they have done some subgroup analysis and they found that it doesn't matter on T stage, rather they found that it is more on ER stage. But it is not a RCT. This is just interesting findings. That's why I shared. So de-escalation. This Italian group was courageous enough to study 6 months and they published it was a negative trial. But again, they were chasing it. In ESMO Breast Cancer 2021, they presented a updated data. This time, their median follow-up is 8.7 years. And they have done the overall survival analysis, long-term DFS analysis. And this time, they have stratified low, intermediate, and high-risk group of their study population. And they have shown that on overall survival, both is overlapping each other. And if you look at 108 months, long is 0.9 and short is 0.8. So there is no statistical difference. And if you look at the risk categorization, low risk and intermediate risk group, it is kissing each other. Only in high risk group, it is separating each other. And it is on 8 years plus time. And from 6 years, it is separating, 5 years, and then it is gradually separating. But only in high risk group. And they have concluded that 5-year DFS in long is 87.9, short is 85.9, hazard is 1.09, and OS is 95, hazard is 1.1. And if you look at the CI, CI is quite good. Hazard is 1, but CI is quite good. And they are recommending that still it is 1 year is a standard, but for low risk intermediate risk, this could be a consideration. So I give salute to this Italian group that even after publishing a negative trial, they're following their cohort and still they are looking whether we can do something. So the question is, can we choose a short duration where Kumardeep was talking? And if we have a PCR with dual blockade, 4 cycle or 6 cycle, then what should be our catch? Shall we continue? If we continue, shall we continue both or single? If we don't add pertuzumab, how much we lose? I come to Dina again. So Dina, for you, after looking at this paper of this updated data of her short trial, don't you feel convinced that we can go for 6 months in our consideration? 8 years follow-up, good, low risk and intermediate risk. Will you be tempting to discuss, or still you will go for 1 year trastuzumab?
Actually, if patient can afford, I will go for 1 year, but most of the patient in our country can't afford any single blockade even. So I think for our low risk and intermediate risk patient, 6 months anti-HER2 with single anti-HER2 blockade, I should consider for our patients.
So this could be a, evidence that you can cite that if you cannot afford 12 months, can try for 6 months. We have some data now. Before we didn't have very robust data. Probably this Italian group is giving us some support, still not in the guideline. So Kumar, I come to you, skipping Dr. Asma. So say we create a scenario, the patient was receiving neoadjuvant dual blockade, and fortunately she developed complete pathological response. So now, what will you do? Will you go for continuation of both or nothing, or only trastuzumab? Let me share with you. I had an opportunity to talk with Peter Smith, if I'm not wrong, for the TNBC guy. So I was asking that when he has designed a neoadjuvant immunotherapy after PCR, why to continue the immunotherapy? He was smiling and said, maybe you have some ground not to continue. Well, that is a different story. So now what will be your take? If it is a PCR, will you continue with trastuzumab, or you will not give both, or you will give nothing?
There is something called recommendation and there is something called practical approach. Half of our patients are coming from the panel, like central government funded panels. So for them, it is not a problem. Continue. They only need recommendation. There should be drug controller of India recommendation. There should be a FDA recommendations. So if recommendation is there, you can continue with anything, whatever is there. For those patients who are under some, who are spending from their pocket, or there is insurance. As you know, insurance cover is not that robust to cover 1 year of pertuzumab therapy or all these things. So that is the catch. When we start, we make them understand that pertuzumab for 6 cycles, and we'll see the response, because you don't know if it is not complete response, you have to change the therapy. So counseling is not for 1 year, because if we counsel for 1 year, most of the people, they will not take. So that is another problem. So after six cycles of therapy, when we see the response, and if it is PCR, most of the patients do not afford, the cash patient, they do not afford to continue for 1 year of pertuzumab based therapy. So what is the next best thing? At least continue with the trastuzumab for 1 year, so that they complete the 1 year of anti-HER2 therapy.
Thank you, Kumar. Farid, what is the nice practice? I know they fund the neoadjuvant dual blockade. So after PCR, are you going for both the continuation or only trastuzumab?
I'm not sure. If she was continuing prior as a dual HER2 blockade, we would normally continue for 12 months. But the trial, the data, what you showed, that.
So you are in UK, you are practicing dual blockade continuation for the rest of the time.
Yeah.
So I am sure it is all over the UK is the same, because you all are following the same guideline.
Yeah. If there was a residual disease, then it could have been slightly different
Then we will
TDM1.
go for TDM1.
Yeah, yeah.
So Shuman is telling that it is not a statistical significant data and we cannot, I agree with you, Shuman, that we cannot make it a recommendation, but the very recent presentation, they have overcome the challenge of this hazard ratio, and they are telling for the low and intermediate risk, they are recommending it could be an option. It is not a recommendation, but it could be an option. So I think we are running short of time. So we understand that still 1 year trastuzumab is the gold standard. If somebody cannot afford, can try with low risk burden for 6 months, because we have some data now, but there's not a gold standard. After PCR, if possible, both, but at least one. And if we don't add pertuzumab and adjuvant, in adjuvant setup, it is near about 5% benefit it gives. So probably we are not losing a huge thing, but if possible, definitely we should add. So next question is, Sharna, go to the next question. That in a young lady, premenopausal, T2, 2.5, N0, M0, grade 3, triple negative, Ki-67, what should be the adjuvant treatment? Where unfortunately, the patient didn't receive any new adjuvant. It is classical adjuvant treatment. For a triple negative, 35 years old lady, 2.5 centimeter tumor, node negative, grade 3, and Ki-67 is 36%. Till now, we have only 4 participants, 5, 6, 7, 8. Welcome, John. So we have 2 more seconds. Short now we stop here. So we have 14 answers. 4 is in favor of 4-cycle AC and 4-cycle taxane. And 9 is 4-cycle AC with 4-cycle taxane with platinum. And 1 is giving in favor of giving capecitabine for 6 months. Great. We are so happy to see the answer. So now I go to our local faculties, Dr. Asma. This lady, what will be your take for adjuvant triple negative young lady? Tumor size is not very small. Grade is 3.
Thank you. Obviously, I go for chemotherapy. And
What
this chemotherapy, yes, 4-cycle AC followed by taxane with platinum. Usually, I'm in favor of this, but still now we are practicing only AC followed by T for this patient.
So you are in favor of giving adjuvant platinum,
yeah,
taxane, and AC.
Yeah, but
Dina,
we are not practicing so much till now. We are in favor.
You are in favor of doing it.
Yeah, in favor.
Good. So Dina, do you agree with Asma, or you want to change something?
No, I'm agreed with Dr. Asma, and still we are practicing only AC followed by T, but I am in favor of adding platinum to taxane after 4 AC.
So both of you are doing ACT, but you are in favor of adding platinum in adjuvant setup. Kumar, are you using platinum in adjuvant setup?
Usually we advise for BRCA testing. BRCA for this kind of triple negative young patients, it is around $8,000 is the testing cost for. So most of the patients are doing BRCA. So we start with the AC, dose dense. By the time we start for the paclitaxel, we get the reports of BRCA report is in hand. So if it is positive, definitely we are giving taxane plus platinum combinations. If BRCA is negative, we are not pushing for platinum. But definitely she is a candidate for dose dense AC followed by weekly Taxol or 2 weekly Taxol.
Great. So if you look at the papers that in early stage 1A, 1B, there is nothing, but adjuvant chemotherapy is not very big player. But if you look at the PATHCR is a big player. And if there is residual tumor is a big issue. But it is 1A, 1B, but this tumor is not. But if after neoadjuvant, if there is residual, the recommendation is capecitabine. So as now, even the scenario is uncommon because nowadays we all know that most of the cases TNBC is supposed to be treated by neoadjuvant therapy. So Kumar, let me come to you that if it a neoadjuvant chemotherapy, some residual, what is your give? You give only capecitabine or you do something different?
No, because most of the time we have to, because for those patients who are centrally funded, central government funded or state government funded, or those for the insurance sector, we have to give recommendation. I mean, the approval, NCCN recommendation, FDA or DGCA approval is there or not. So we cannot do something which is still not been recommended by these agencies. So we give capecitabine only.
So if there was no barrier, if you are free bird, would you do something different, Kumar?
Till now, I have not done something other than that.
Okay. So Dr. Asma, patient was on neoadjuvant chemotherapy. Unfortunately, there is some residual tumor. What will you give? You give her capecitabine, or you give her capecitabine plus platinum, or you give her some more platinum, then give capecitabine. I give you 3 options.
Yes. Usually we go for adjuvant capecitabine.
Only.
6 to 8 weeks. Yes.
Great.
We practice.
Okay. So that is the point that we are talking. The CreateX was the trial that has established it. And then Chinese have tried to do it in a larger population, but in a longer duration, but a lower dose. But the problem of the Chinese is that it is only in China and only 5.8% was neoadjuvant chemotherapy group. And the capecitabine dose and the duration is questioned. So there was some trial, Peacock Acrine EA1131. They tried to compare capecitabine with platinum. Unfortunately, here platinum failed to beat capecitabine. So still capecitabine is the gold standard. This is a trial of GChem 2003 and 11. This trial had a bit disappointing result with capecitabine. They said the subset is getting a benefit. So John, you are here in triple negative. If there is no adjuvant, no neoadjuvant. So what is your practice? Give acetaxane or dose-dense or platinum?
Dose-dense AC weekly carbotaxol for high risk, or for patients who are essentially having, like your lady, the T2 grade 3 triple negative lady you presented. So our standard would be dose-dense AC 2 weekly and now weekly carbotaxol. And then we do use adjuvant capecitabine post-operatively in patients who haven't had a complete pathological response. So that's our standard.
So, I mean, if it is an adjuvant, do you go for platinum in adjuvant?
We do.
Well, I mean, the high risk group?
Yes. So grade 3 T2 node positives. Okay. Our view is, that they're going to get one go.
After neoadjuvant 8 cycle finished, will you add some more?
So we will give, so if they've had AC carbotaxol neoadjuvantly, and then they've had surgery, and then they still have residual disease in either breast or node or both, then we will give 8 cycles of adjuvant capecitabine, 1250 mg per meter squared, day 1 to 14, weekend off.
Okay. So we can say that in TNBC that we should be considering the adjuvant AC, dose-dense AC, Taxol, and in high-risk group, we can add platinum in adjuvant, but it may not be a great player like the neoadjuvant, but still there is some recommendation. And if it is after neoadjuvant, after all the cycle is exhausted, then capecitabine 1250 milligram BID, the standard dose for 6 months is still the gold standard. But the challenge is, John, somebody took 4 cycle, then done surgery, then took the 4 cycle text and sandwich technique, old school of thoughts. Then what we are going to do? Will you go to add capecitabine in the end? Because it happens. Still it happens.
Yeah, the rationale, the scientific rationale for me is that the fact that there's residual disease after chemo tells you that they had clones that were resistant to taxanes, platinums, anthracyclines, and cyclophosphamide. So you're adding in another agent with another mechanism of action. If you're in the adjuvant setting and you're giving for the risk of microscopic disease, you don't at the moment have a mechanism of determining whether after your taxane there's still residual microscopic disease. Undoubtedly, we will have that technology one day, and when we do, then perhaps we'll add, or I would then consider adding capecitabine adjuvantly after taxane. But until you've got that trigger to make you, until you've got the scientific evidence to add capecitabine, I wouldn't just do it for the sake of doing it. That's my view.
So what is your comment about the Chinese, the 650 low dose 1 year versus this 6 months, 1250?
I think it's a bit of a blunderbuss to me approach, just giving it to everyone, and in amongst there will be patients who didn't need it and have had it, and God forbid they've had some severe side effect from it, which they could have avoided. I'd like to be more selective ultimately.
Thank you, John. So for triple negative, we can say that still capecitabine is our good friend. And now CDK4/6 inhibitor is the most discussed issue in the world of breast cancer. Shona, next question, please. Very simple. CDK4/6 inhibitor with endocrine therapy is recommended as adjuvant treatment for high risk hormone receptor positive, HER2 negative, node negative breast cancer. Monarch E trial was an interesting trial where they have tried CDK4/6 inhibitor in adjuvant setup, and they had some interesting data. So this question came, can we use it? So only 3% joined. That Monarch E have shown is a positive trial showing CDK4/6 adjuvant benefit. But on that, can we accept? If yes, why? If no, then why not? So we have given the answer true, false, and true in select case. We said it is recommended in node negative breast cancer, HER2 positive, HER2 negative, hormone receptor positive. So we have 13. Sorry, I think we can stop now. So 3 out of 14 is true, 3 is false, and 8 is true in select case. So 8 is 50-50. So good. So let's see what Monarch E actually showed. Monarch E actually concluded that abemaciclib, when combined with endocrine therapy, is first CDK4 inhibitor to demonstrate a significant improvement of DFS in patient with hormone receptor positive, HER2 negative, high risk, and it should be node positive. And there was a meta-analysis done, published in 2021. They have taken out these 3 trials, Monarch E, Pallas, and Penelope B. And finally, they have concluded that it has shown benefit in N2 and 3 subgroup. But however, overall evidence favoring the use of this combination regimen was inadequate. So till now, it is not a recommendation. So Dr. Asma, are you practicing it in adjuvant? CDK4/6 in high risk group. Please unmute yourself.
Thank you. Till we are not using this CDK4/6 inhibitor along with hormone therapy, we use only hormone therapy. CDK4.
But Monarch E, don't you think it is very?
It's a good study. I am in favor of this, but we are not practicing here. This.
Tina, after looking to this data, will you be trying to discuss about this option with node positive patient of yours? Well, there is a chance of recurrence. There is a good data. Dina, will you be discussing?
If there is a N3 disease, a high-risk patient, then I can talk with the patient, but I still in favor of only hormone without CDK4/6 inhibitor in adjuvant setting.
Great. So Kumar, are you using, I know you are guided by funding and non-funding, but is there any out-of-the-box practice of?
So for N2, N3 disease, what I usually do is, if they are premenopausal, I follow soft and text data, make them postmenopausal with GnRH analog, and then use AIs, exemestane along with that, and 6 monthly zoldronic acid, irrespective of their bone health status. So that is my practice usually for high nodal disease burden.
So
I've never
CDK4/6.
No, never.
John, any thoughts on it? I know in private, what is your thought? I know you don't practice it. What is your thought on monarchy?
So I think in the high-risk subset, as you said, it showed improvement in invasive disease-free survival in the group at 2 years, but I don't think it showed statistical significance in the patients with, in postmenopausal patients. It was only in premenopausal. So there was only really one subset that seemed to benefit. And I'd also argue that 2 years invasive disease-free survival, we know from the natural history of breast cancer that I don't think you can really draw your line at 2 years. At the end of the day, we see patients with metastatic disease who have disease control beyond 2 years on these agents. So it'll be interesting to see how the data matures. And then you've also got the Pallas and Penelope B studies using palbociclib, and they didn't show any statistical significance. So you've only really got the evidence for abemaciclib, and on that basis, I think the jury is still out. So let's watch this space. Interestingly, I think overnight in ESMO, there was data presented on Pearl, wasn't there? Using palbociclib or adjuvant or chemo versus adjuvant CDK4/6. And again, it didn't show anything significant, I gather, apart from quality of life. So again, it doesn't look great for CDK4/6s at the moment.
So John, there is a question came to the chat box. Let us cover it. That as soft text trial, that what Kumardeep was telling, yes. But sometimes doing this GHRH analog for 2 years, every monthly. So what is your comment about using ovarian ablation by radiation?
Interestingly, probably about 16 years ago when I started as a reg, my boss, my consultant then, really nice chap, Graham, he used to do radiation ablation of the ovaries, single foregrade fraction, I seem to remember, on SIM. And we don't do that anymore. I would say if, radiation has potential long-term effects. If you can avoid radiation, ask your gynecologist if they can do a lap oophorectomy, at least then you've got less long-term unwanted effects from exposure to radiation, or alternatively, LHRH. So I don't use radiotherapy ablation myself. Do you, Kamal?
But John, I don't. But where last week I read an interesting article that they were studying the recipient of LHRS agonist and antagonist, both group. In prostate cancer, they found 27+% are not maintaining their time. It is a very interesting paper I read. So it is practically for everybody. So you see, it is a matter of cost, it is a matter of compliance. And if you give a radiation one shot, it is done. So taking some risk, country like us, where it is an expense, it is a issue of logistics. 16 years back, what your boss was used to do, will you recommend it? If you not,
so I would also,
what is the reason?
I'd also argue this though, the benefit of ovarian suppression and AI, we're not talking 20% versus 3%, the incremental benefit is not huge. And the one beauty about LHRH is that you can stop it and de-escalate them back to tamoxifen if they don't like the side effects. Whereas if you've done ovarian ablation, you know, that's it, it's over. Yeah. So I would say that having something you can stop and reverse if the patient doesn't like the effects of it, you know, assuming they're happy to accept the slightly higher risk of disease recurrence, I'd say that is also a factor worth considering in this.
So you are in favor of permanent and temporary, that you are concerned about the temporary withdrawal. So once we withdraw, she can come back to her normal.
Yeah, I'd say that is a benefit as well. You know,
Yeah.
It's not a one-way street.
Okay, Farid, we are going to the last question. Do you have anything to comment on this CDK4/6? Any comment? Want to add anything here?
Nothing additional, thanks.
Thank you. Farid, so we go to the last question. Sharna, so now we cannot finish breast discussion without BRCA. So PT1, N0M0, grade 3 RPR negative, HER2 negative, it is a triple negative, KI67 36%, BRCA positive. Already received 8 cycle of neoadjuvant chemotherapy, and there are some residual. What will be your take? Capivasertib plus olaparib, only olaparib, pembrolizumab plus chemotherapy, or atezolizumab with chemotherapy? So with this BRCA positive, we are in the era of BRCA. Olaparib is getting every day new and new approval.
Well, is that post-op YPT one?
Yes, YP, it is YP.
Okay.
Good point.
So 10, 11, till now, 12. So I think we can stop it here because nobody's. So 1 out of 12 in favor of only capivasertib, 6 out of 12, 50% in favor of giving capivasertib and olaparib. Everybody loves olaparib. 4 out of 12 is in favor of olaparib. 1 is of pembrolizumab. Okay. So Olympia trial. This is an interesting trial, multi-country, multi-center trial. And they have recruited a huge 1,836 patients. And they have a funny way that they will be looking for first disease-free survival. And once it's achieved, then they will go for OS. So the conditional planning they have done. And it's interestingly very fairly distributed, both the groups. If you look at the olaparib and placebo arm, sorry, I missed that. They have selected germline mutated this BRCA1 to mutate HER2 negative, either hormone positive or negative, stage 2-3 breast cancer, or lack of PATCR to NSCT. So both with NSCT or without NSCT, they have taken these things. So when they have seen the ITT group disease-free survival, there is a fair separation. And they have, when they have completed the mature cohort, 900 patients who have completed 3.5 years follow-up, there is a interesting separation. And distant disease-free survival is also good, but OS is not separate. But I heard the presenter explaining that they need to wait to see the OS data. So they are optimistic to have a OS benefit. So the question is, shall we ask for BRCA testing for all HER2 negative breast cancer patients now? And shall we consider olaparib as standard of care as adjuvant in this group, or we effort to select group? So I come to John, to you. What is your take on this Olympia trial? Very exciting.
So we took part, we took part in the trial with Andy.
So I asked the correct person. You are a part of the Olympia trial.
Yeah, we took part in BART. So we took part, screened patients. So the patients who have had neoadjuvant treatment, yeah, the data suggests post-treatment, if they've had T2 or 2 centimeter tumors or bigger, or no positive disease presentation, that offering them adjuvant olaparib adjuvantly is the right thing to do. Obviously, the data has only recently been presented, so NICE is yet to to release access to it, but I suspect it will. What will need to be much easier, I think, to access is rapid genetic testing, for these patients. Even we in London, in UK, in the NHS struggle to get patients tested, I would say, in a timely fashion to determine their BRCA status in the course of their treatment. It just takes quite a long time.
Kumar, comment on Olympia trial. Very exciting.
Yeah, as I have told you, all triple negative young patients or those with a positive family history, those with a bilateral CA breast or male breast cancer, we are routinely advising for the testing, and
Yes,
they're getting it testing done. So, but in practice, I have not incorporated Olympia like adjuvant olaparib. Still, it has been reserved for the metastatic disease and all. So, in practice, I have not done.
Are you quite optimistic of?
Yeah, definitely. I am optimistic of probably in a couple of years we'll see like olaparib in the adjuvant setup.
You see, some PARP is coming also in neoadjuvant. They are trying on neoadjuvant. There are some partial success with neoadjuvant also.
Right.
So everywhere we see PARP. I mean, very soon maybe all subside of the disease will be covered by PARP. Okay. So Kumar, Farid, any comment?
Nothing additional.
I have one comment for it. As a surgeon, in all this situation, this high risk group, do you tailor your practice of surgery, like conservation to radical mastectomy of this triple negative or this HER2 positivity, heavy burden, young or strong family history, anything? Does it influence you as a surgeon to think, well, shall I go for conservation? There is a high chance of recurrence. The patient may recur. I need to go for a landed mastectomy. So why not go for mastectomy?
Thank you. It does matter, really. We have to consider various factors. TNBC patients below 60 years, we would like to get genetic testing done. And that's what we practice in UK. So that's number one. And if they have got genetic mutation, then we would discuss this patient as well when it comes to surgery post-neoadjuvant chemotherapy, what type of surgery we're going to go. So a detailed discussion is undertaken, and some patients would prefer to have both breasts removed and immediate and reconstruction afterwards. And if there are nodal positivity post-NSCT, then obviously we would consider a delayed reconstruction unless we do DF. Now, case-based selective cases, we wouldn't go for like one size fit all. It would be individualized, discussed, and agreed. But some patients do prefer to have breast conserving surgery if they've got good response post NSCT, and we would usually like to put a marker clip, and then we either go for a radiofrequency guided wide local or a simple wire guided wide local excision. So these are various types of practices open to patients, subject to their wish and MDD recommendations. So we are flexible on that.
Yeah, in NSCT by dual blockade or in triple negative, we get a 50-60% sometimes PAT-CR. That is a good thing. But when we don't get a PAT-CR, we feel bad, and that gives a bad message. That is a bad biology. So when a patient is getting a neoadjuvant and not getting a PAT-CR, I mean, not a very good response, does it influence your decision of conservation? Because we understand it is a bad biology, there is a fair chance of recurrence.
Not really, because you know very well that the trials that came from Sweden, 50,000 cancer patients, where they found breast conserving surgery patients followed by radiotherapy, they survive longer than actually mastectomy groups. So just because it's TNBC, we wouldn't just necessarily offer mastectomy. But certainly there will be some influence if patient has got BRCA mutation. That then we would like to discuss this with the patient, the options of mastectomy, bilateral mastectomy, and reconstructions, immediate or delayed.
John, I have a related question here. The point that Farid took over, that the Swedish trial, they have shown that the early breast cancer, the conservation outcome is better than mastectomy. what do you think that could be the reason of this outcome? I mean, why is it radiation playing any role, or because the data is quite convincing? I mean, just
yeah, I suppose anatomically, if you do a mastectomy and if you do whole breast radiotherapy, is there just a slight improvement in control of microscopic disease that is beyond the boundaries of your surgical mastectomy specimen, that just that small, tiny percentage of patients that there might be residual microscopic disease that's managed to just track beyond where your mastectomy specimen is? I'd have to have a little think about it. I don't know. I don't think there's any clear reason for why that should be the case, to be honest.
So there were hypotheses I read on that article. They were thinking that probably, in mastectomy, the role of adjuvant radiotherapy is only 5% overall survival benefit, but when radiation is playing a big role in whole breast, they're thinking that the huge contribution of radiation could be a player in breast conservation, but this is again a hypothesis. So I think we have—
How about late toxicity, Kamal? So, will you then see the dip in the curve, though, from late effects of radiotherapy and cardiovascular disease in the patients who've had whole breast radiotherapy? Will it rebalance the scale later?
Yeah, as I said, it is a hypothesis. Nobody knows, but they have observed it, and it's a huge number of patients. Nobody can ignore it. So now the believer of conservation can bring a noise that we have a better data, but still it is not a head-to-head trial. So we are almost at the end. Next week, we will be discussing on endocrine therapy. Today, we didn't discuss the adjuvant endocrine therapy and also radiation. Radiation will be another session. And Dr. Mustafa Aziz Shuman will be the moderator next week. And Dr. Zakirullah and John will be the overseas faculty. We will decide the local faculty later on. And everybody is welcome. And I want to thank our academic partner, Roche, for supporting this initiative. And I want to thank our today's overseas faculty, Dr. Kumardeep Datta Chaudhary, who is a man from Sylhet, moved to Assam, now working in Delhi. Thanks for joining. Thanks to Farid and John for sacrificing the holiday and sacrificing the time cycling with son, and you joined with us. I hope you had a good time with your son cycling. And thanks to Dr. Asma Siddiqa and Dr. Ruxana Rabbani Dina, and also to our all participants who have participated in the poll. So now I will like to ask the last week winners declaration. May I see who were the winner of last week? Shorna, Tanya, please show the name, 3 names of last week. I think you need to stop and open it and then again open. Shorna, you need to stop it. Tanya, okay. Then open the screen, then share. So I see the winner. So can you share it now? Thank you, Brigadier General Bretelahi, for joining. Thanks for your appreciation. Nice discussion indeed. So we tried to touch upon the everyday issue. These are everyday we are facing these challenges, and still we don't know the real answer. So Shorna, so if you cannot share, so let me tell you the names. Okay, Tanya, let me tell the name. Dr. Arman Raja Chaudhary, Dr. Mannan,
Dr. Aditi Chaudhary.
Aditi Chaudhary, Abdullah Mannan, no? And Dr. Aditi Chaudhary. So these 3, congratulations to all 3 of you. And hopefully next week we will declare the winner of today's session. And I want to thank everybody again. Sir, would you please close the session?
Thank you all.
Sir, hi, sir.
Bye-bye.
So we want to finish the session here and see you all next week, same time. We will be talking on endocrine therapy. There are many questions. I think most of them we have already covered, so I'm not going there. And because already we are late by 18 minutes. So I hope you have enjoyed, and this discussion format will continue. So see you next week. Stay safe. Goodbye, everybody.
Okay, bye-bye.
Assalamu alaikum.
Allah Hafiz, everybody.